This lecture is on balance of other electrolytes in addition to sodium. We have a whole separate lecture on sodium balance that you may watch before this one. Now we're going to talk about the remaining electrolytes. In this lecture, we'll describe the normal levels and function of potassium in the body. Compare the signs and symptoms of low and high potassium levels. We will also talk about calcium, magnesium, and phosphate, looking at the normal levels of each of these electrolytes and comparing the signs and symptoms of low and high values of each. Potassium is the major intracellular electrolyte. It's very high within the cells and very low within the blood. Potassium is shifted into cells rapidly once it's absorbed from the diet to prevent fluctuations, as high potassium in the blood can be dangerous and can disrupt electrical membrane potential. The normal range for potassium is 3.5 to 5 milliequivalents in the blood. The average dietary intake is 40 to 150 milliequivalents per day. The functions of potassium are intracellular osmolality, resting electrical potential, acid-base and volume balance as it relates to proton and sodium levels, metabolic functions, and glycogen deposition in the liver and skeletal muscle. The signs and symptoms of potassium imbalance are mainly neuromuscular, but they can also range in terms of digestive and urinary symptoms. Low potassium can lead to muscle weakness, respiratory difficulty or respiratory arrest, cardiac dysfunction, polyuria, polydipsia, and orthostatic hypotension, which is a change in blood pressure from sitting to standing, constipation, intestinal distension, anorexia, nausea, vomiting, and paralytic ileus or paralysis of the digestive tract. Most of these are related to the changes in electrical activity that can be caused by low potassium. High potassium signs and symptoms are also related to changes in electrical activity. You can have muscle weakness also from high potassium. Similarly, cardiac dysrhythmia and paralysis. In addition, high potassium can lead to tingling of the lips and fingers, restlessness, intestinal cramps, and diarrhea. Let's look at the mechanisms of low and high potassium. Low potassium is hypokalemia. In labs, you will see a serum potassium less than 3.5. I want you to notice how low the potassium already is, because a small change in potassium in the blood can lead to a huge change in function. Low potassium can be caused by insulin-related potassium uptake, meaning that after a meal or after insulin administration, potassium is drawn into the cells. Inadequate intake of potassium can also happen, although it's rare. There's also redistribution of potassium to different compartments if there's an acid-base imbalance. We call this the HK shift, and I'm going to show you this in the next slide. You can also have GI or renal losses of potassium due to increased fluid flow. And this is due to a particular potassium channel that increases when fluid flow to those epithelium increase. What happens to the excitability of cells when you have low potassium? What happens when you have low potassium in the extracellular fluid is that you have a change in the potassium gradient between the intracellular and extracellular fluid. This potassium gradient is very important for setting the resting membrane potential or the electrical potential of cells. When you have a greater gradient, you have a larger differential in membrane potential, meaning that the membrane potential difference will become more negative. When the cells become more negative or hyperpolarized, they are less excitable because it's hard to get them to electrical threshold in order to form action potentials to activate those neuromuscular, cardiovascular, or smooth muscle stimuli. High serum potassium is hyperkalemia. This is anything above 5.5, and again, small changes can lead to large changes in function. This can be caused by excessive intake. For example, patients who ingest salt substitutes. They're trying to do good by reducing their salt intake, but they choose salt substitutes in their diet, which often are high in potassium. Redistribution, again, because of acid-base changes. Lack of excretion or renal failure. Also, trauma to the cells, particularly trauma to the muscles. So think of something like rhabdomyolysis or another trauma which could break down cells. When you break open cells, you release the potassium inside, and that can cause a hyperkalemia. A deficit in insulin can also cause a hypokalemia, particularly when it's matched with an intake of high potassium, because that insulin normally acts to bring the potassium into the cells after a meal. What will happen to the excitability of cells? High potassium in the extracellular fluid will decrease the gradient of potassium between the intracellular and extracellular fluid. This means that the resting membrane electrical potential of cells will be more positive or hyperexcitable. If the cells are more positive, it's easier for them to get to threshold, and they will be hyperexcitable for a period of time. Unfortunately, though, this is followed by a lack of returning back to baseline, and that loss of reset of membrane potential makes it difficult after a period of hyperexcitability to get stimuli again. So, why do we see muscle weakness in both high and low potassium? Patients will say they're fatigued or their muscles are weak. Why do we see fatigue or muscle weakness in both of these conditions? Think about it for a second. Draw out your cell, put your potassium inside, your sodium on the outside, and remember that potassium is important for setting that gradient of electrical potential. Okay, what did you come up with? My answer is that both. You will get fatigue or muscle weakness in both low and high potassium situations. And why? In a low potassium situation, it's difficult to get to threshold because of that increase in gradient. In high potassium situations, it's easy to get to threshold, but it's difficult to reset to get new action potentials or new stimuli to the cells. In both cases, patients will present with muscle weakness and fatigue. Let's think about the regulation of potassium. There's three main considerations for the regulation of potassium levels. The cellular uptake of potassium, we already talked about insulin. Cellular uptake of potassium is also stimulated by aldosterone, beta-adrenergic stimulation, and alkalosis in the blood, meaning that you have high blood pH, or the blood is too basic. You can also get release of potassium from the cells. We talked about potassium being released in trauma, but here we're talking about hormonal or environment stimulation. Alpha-adrenergic stimulation, with, for example, excessive exercise, can release potassium. And acidosis, or at low pH of the blood, high acidity, can cause release of potassium from the blood. So we have both cellular uptake, or potassium shifting into cells, and cellular release, or potassium shifting out of cells. It's also possible to have renal, GI, or other losses of potassium through excretion. There are urinary mechanisms that cause an increase in excretion of potassium. You can have potassium lost in the stool, for example, through a high fluid diarrhea that activates potassium channels. And you also lose potassium in sweat. Okay, on to calcium. Calcium is found primarily in the bone. About 99% is found in the bone, only about 1% is circulating. Of that 1% that is circulating in the blood, about half of it is bound to plasma proteins, and about half of it is free or ionized. It's the free or ionized potassium that is available for signaling, and so that is the amount that is actually functioning within the body. The normal range of calcium is 9 to 10.5 milligrams per deciliter. The normal range for ionized calcium is 5.5 to 5.6. The main functions of calcium are many. Calcium is a structural element of bone and teeth. It's also very important for cellular signaling pathways. It's a cofactor for enzymes. Remember, we learned it's an important second messenger in second messenger pathways. It can stabilize plasma membranes. It's important for neurotransmitter release in neuromuscular and neuron function. And it's also important within the muscles to allow muscle contraction. The signs and symptoms of calcium imbalance are also related to its functions. A low calcium can lead to paresthesias or tingling of the mouth and digits, carpopedal spasms or leg spasms, spasms of the larynx, intestinal cramping, hyperactive bowel sounds, hyperreflexia, seizure, cardiac dysrhythmias, convulsions, all the way up to tetany, and it can even be fatal. So low calcium is dangerous. High calcium can lead to fatigue and weakness. It also can lead to GI symptoms, anorexia or no desire to eat, nausea, constipation, and central nervous system symptoms, confusion, decreased mental status. High calcium can also lead to kidney stones and impaired renal function. Let's look at the mechanisms of low and high calcium. Low calcium is hypokalemia. This would be a serum calcium level which is less than 8.5, or a free ionized calcium level which is less than 4. It can also coincide with a high phosphate value because calcium and phosphate bind together. So if there's a lot of phosphate in the blood, that calcium will be bound up into that phosphate. It's caused by inadequate intake of calcium, removal of parathyroid glands, and we'll talk about the importance of parathyroid hormone in a minute, vitamin D deficiency, bone metastases, increased calcium deposition. That's only if those bone mets haven't started breaking down bone, because we'll see that bone mets, if they're breaking down bone, can cause calcium to be released. So this would be deposition of calcium in the bones. Pancreatitis, which can lead to more free fatty acids and binding the calcium. High pH, alkalosis, means there's less free calcium around. Or low albumin. Low albumin means there's less plasma proteins binding up the calcium, and you can lose calcium for that reason. Finally, end-stage renal disease. What will happen to the excitability of cells? Low calcium can decrease the threshold of cells in their electrical potential. That means you have an increase in the excitability of cells if calcium is low. Hyperkalemia is high calcium. This is a serum calcium level greater than 12. It can also coincide with a low phosphate level. It's caused by high parathyroid or a parathyroid secreting tumor, bone metastases if they are breaking down bone. So we talk about hyperkalemia of malignancy, and that's usually due to tumors breaking down bone and causing release of calcium from that broken down bone. That's a very important sign of cancer that you want to pay attention to. Excessive vitamin D, or prolonged immobilization that leads to bone breakdown. So essentially, if you have breakdown of bone for any number of reasons, whether you have excessive hormone secretion breaking down those bones, cancer, or some kind of other process breaking down bones, that can release calcium and lead to a hyperkalemia. Hyperkalemia can also coincide with acidic blood or low blood pH. That's because an acidosis will mobilize more free calcium. And having more free calcium in the blood functionally is a hyperkalemia. So what would happen to the excitability of cells? When you have high calcium, that essentially decreases the excitability of cells. It does that by stabilizing the membrane and making a higher threshold for activation of membrane potential and excitability. So high calcium leads to decrease or loss of excitability. We've talked now about both potassium and calcium determining changes in excitability of cells. So I want to make sure that we touch on this figure from your textbook about the involvement of electrolytes in excitability. So the excitability of cells depends upon the electrical and chemical gradients of sodium, chloride, potassium, and calcium. Electrical gradients are important for many cells in the body. They're particularly important for the heart, the nervous system, skeletal muscle, and smooth muscle. Okay, so everything. Let's zoom in on this figure and I'll show you the excitability changes with potassium and calcium. Okay, so think back to your early studies of physiology in your previous courses. This is a normal diagram of an action potential. Remember, for a cell to reach action potential, it has to go from its resting membrane potential up to threshold. Once it hits threshold, you have this all or nothing action potential that eventually comes back down to rest and resets. Now let's look at potassium and calcium. Here's the potassium changes. When you have low potassium, you have a decrease in membrane potential and a decrease in excitability. When you have high potassium, you have an increase in membrane potential and an increase in excitability. As we discussed previously, both of those can lead to difficulty ultimately in generation of these stimuli or these action potentials. In the case of low potassium, you can't get action potentials to begin with because you're too far from threshold. In the case of high potassium, you'll get some action potentials, but once those action potentials happen, you're unable to reset back down to rest to get the action potentials to happen again. So potassium can lead to changes in excitability because of the decrease or increase in membrane potential. Calcium, however, changes the threshold. High calcium, so here's the diagram for calcium. High calcium can increase the threshold. If the threshold is increased, it's harder to reach that threshold and you get a decrease in excitability. Low calcium can decrease the threshold, making it easier to get action potentials and causing an increase in excitability. Okay, a few more electrolytes to go. We can't talk about calcium regulation without first talking about phosphate. So let's finish up with phosphate and then we'll talk about the regulation of calcium and phosphate because they go together. So phosphate is located 85% in the bone, mostly bound to calcium. It's also found intracellularly as inorganic phosphate and part of phospholipids and ATP. Low phosphate is hypophosphatemia, or less than 2.5 milligrams per deciliter. It's caused by hormone deficiencies, particularly vitamin D deficiency, alcohol abuse, malabsorption syndromes, and respiratory alkalosis. It's only clinically significant when it's very severe. Patients with low phosphate might show low heart rate, heart block, and other dysfunctions. But again, it's not incredibly clinically significant unless it's very severe. High phosphate is greater than 4.5 milligrams per deciliter. It can be caused by low filtration of the kidneys or decrease in renal function. It can also be caused by breakdown of metastatic tumors. For the same reason that you have high calcium when you break down bone, you can also have high phosphate when you break down bone. Because phosphate and calcium go together, a high phosphate can soak up the calcium and the patient will have symptoms of low calcium as well. So now on to the mechanisms of calcium and phosphate regulation. The main contributions to calcium and phosphate regulation are through parathyroid hormone and vitamin D activation. Parathyroid hormone ultimately increases calcium and decreases phosphate. We'll talk more about parathyroid hormone during our endocrine and our skeletal lectures. Vitamin D causes an increase in calcium and a decrease in phosphate, just like parathyroid hormone. We'll talk about vitamin D next week in our skin lectures. Calcitonin is also involved in calcium and phosphate regulation. It decreases calcium, although we're unsure if this is clinically significant in humans. It's very common to find this in animal models, but it has not been repeated, at least from what I know of the current research in humans. pH can regulate calcium because a low pH increases the ionization of calcium, causing more free calcium. And a high pH decreases the ionization of calcium, causing less free calcium. Phosphate levels can affect calcium. High levels of phosphate can bind calcium and you have less free calcium. Excretion of phosphate or low levels of phosphate can increase free calcium. That's why parathyroid hormone and vitamin D, as they increase calcium, also decrease phosphate levels. Finally, one thing I want to mention is that as you move forward in your clinical careers and you learn about measurement of calcium in the blood and you get your lab values for calcium, at some point you're going to need to consider the levels of albumin. So if you have a patient that has low albumin, that can artificially lower the measured calcium. So if you see that a patient has both low calcium and low albumin, you're going to want to calculate the correction to see if the patient truly has low calcium or if that low calcium measurement is simply due to low levels of albumin. Magnesium is located intracellularly along with potassium. It is a cofactor for many enzymatic reactions, and it interacts with calcium and potassium channels. Low magnesium is hypomagnesemia, which is less than 1.5, and it's caused often by diuretics. Could be caused also by malnutrition, malabsorption, alcoholism, or renal dysfunction. Symptoms are very similar for low magnesium as they are for low calcium. High magnesium is greater than 2.5 milligrams per deciliter. It can be caused by renal failure and excessive ingestion of antacids. It can cause depression of skeletal muscle contraction, depression of nerve function, depression of GI function, low heart rate, and respiratory depression. Okay, that's it for the other electrolytes. Let me know if you have any questions.